TopMedTalk.
Today's TopMedTalk is a two-part piece. Please check out the show notes for details as to where you can find the other part.
So this particular afternoon session is about pathophysiology of autoregulation of blood pressure. So that's quite a word salad there. And I'm joined for this particular session by my online co-chair, who's been involved earlier on today, but you may not have met him yet, and that's Dan Martin. Dan, how are you?
Thoroughly looking forward to this session where we're hoping to bring together clinicians and physiologists to really delve deep into this process of blood flow autoregulation to organs around the time of surgery.
So Dan, maybe there's some people arriving just for this session, so just in case they haven't met you before, can you remind us what your current roles are?
I'm now the Professor of Perioperative and Intensive Care Medicine at the University of Plymouth. I've got a clinical job at the Royal Free Hospital in London, so a little bit of commuting to do there. But my real passion between those things is physiology. My PhD was in applied physiology, primarily looking at the work of human adaptation to hypoxia at high altitude, but so really trying to bring together all the elements here: physiology, intensive care, perioperative medicine.
You have a role, I think, in the Physiology Society, the long-standing society.
Yes, a member of the Physiology Society, and working with them on themes like we're doing today, bringing together physiologists and clinicians to work out what patients really need to improve patients' outcomes. So really bringing the best of both of those fields together.
So if you haven't had a chance to watch the long-form lecture, but as I say, is available on demand. So I'm going to go first to Sol Aronson and say welcome, Sol.
Hello, Monty.
So Sol, believe it or not everyone in the world will know you. So I probably should say a little bit more about you. Why don't you introduce yourself, actually, Sol? I know you extremely well. Which bits would you like to highlight?
Father of two, devoted husband is good enough for me.
And you're working at Duke University Medical Center in North Carolina at the moment. I think most people would know you as a cardiothoracic anesthesiologist and one of the great leaders of ultrasound in that space.
I am a professor of anesthesiology and population health science at Duke University and the executive vice chair of the Department of Anesthesia.
Now, apart from being a key participant in those pokey papers about blood pressure that I referred to, you've also had a long-term research interest in blood pressure that we're not going to go into at the moment. But as I said, you led and are the chairman of EBPOM USA, which takes place in Chicago, or has done and was supposed to be this year, even though you actually live and work in North Carolina. So could you introduce our next guest for us and explain the link with Chicago and how he ended up there?
With pleasure. So Chicago is a home, spiritually as well as mechanically for me. I still have residence there. And with great pleasure, I would just simply say the EBPOM family and the EBPOM USA family in particular has bonded and aligned with Dr. Hogue, who's the Econoff professor and chair of the Department of Anesthesiology at Northwestern, and has been graciously a part of the EBPOM family now since we really launched, and is our co-host when we have our annual Chicago meeting there. Of course, sometimes that's on the pavement and sometimes it's in the ether. This last year it was in the ether. One of the things that we have introduced this last year to the EBPOM sort of vernacular is what we call the Pathophysiology of Recovery series, something that we are very excited about. And this year our inaugural, if you will, program was, as you stated, Monty, focused on autoregulation and blood pressure physiology. Every year we're going to pick a topic. We're going to deeply dive down into that topic and let the discussion and the dialogue and the deliberations be published as a white paper in the Journal of Perioperative Medicine, as we would expect this year's session that Dan is going to lead us through to be the same. So it's with double privilege that I get to introduce to you Dr. Hogue, who's sort of our keynote for the cerebral autoregulatory focus of this year's Pathophysiology Recovery session, and also just as a longtime friend of the EBPOM family and our co-host of our Chicago meeting. So, Chuck, great to see you again.
Yeah, as well, Sol and Monty, and it's my pleasure.
Chuck, if I may, an absolutely tantalizing lecture and really been taken more recently. I've seen you give a few lectures now by this idea that we can exploit cerebral near-infrared spectroscopy to somehow understand where the lower limit of autoregulation in terms of blood pressure may be for the brain. Could you just expand on that a little bit before I hand you over to Dan and to Sol to ask you some questions as well?
We've been monitoring autoregulation for some time, and there's several approaches. You need to be able to measure some flow or some mechanism of measuring cerebral vasoreactivity, which derive from measuring some surrogate or cerebral blood volume like ICP. So the idea with near-infrared spectroscopy is that we could take the signals from the machine and focus on low frequencies associated with autoregulation and therefore derive a surrogate of cerebral blood flow for measuring autoregulation. Not to get into too much detail, but near-infrared spectroscopy derives its regional cerebral oxygen saturation by looking at the differential absorption of photons for oxygenated hemoglobin versus either reduced hemoglobin or total hemoglobin. There's a isobastic waveform of about 801 nanometers where it absorbs both oxygenated and deoxygenated blood. So it gives you a derivative of total hemoglobin. So why is that important? Well, you could actually measure this signal of total hemoglobin and get an idea of the vasoreactivity. In other words, if you are reaching the lower limit of autoregulation for your brain, all the arterioles vasodilate. This results collectively in an increase in cerebral blood volume in the brain, which if you're measuring ICP may cause the ICP to go up if low compliance. But it also increases the total hemoglobin value. Conversely, if your blood vessels vasoconstrict because your blood pressure is going up, this causes the total hemoglobin actually to go down. So by measuring this total hemoglobin derived from near-infrared spectroscopy, you get a little bit of an indicator of vasoreactivity, which also then indicates the mechanism of cerebral autoregulation. So there's a wealth of data in these machines other than just the value that they're putting on the monitor. And if we could look at these values, filter them to look at the frequencies associated with autoregulation, we could then combine these with blood pressure to get an idea how they change in relationship to each other. So if you're autoregulated and your blood pressure changes but flow stays the same, then you know you're okay. You're on the plateau. But if they now become correlated and your blood pressure goes down and your flow goes down or your vasoreactivity goes up, you know that you've reached the lower limit of autoregulation and maybe we should dial the pressure up a little bit. So there's a wealth of information in these machines that it would be nice if we could get these out commercially, but we could do it in a research capacity. And so I think that we haven't reached full capacity of using near-infrared spectroscopy in the operating room to the benefit of patients.
It's tantalizing as well because it sounds as though we could have something that's clinically practical and viable soon. But I think what the rest of this discussion is going to get into is if the brain is happy, we've had quite a few conversations about this, is it okay to assume that other organs are happy? Do we know if the autoregulation, where in the hierarchy is the kidney compared to the brain or the muscle or the gut? And if we're very cerebrocentric, can we be hurting other parts of the body, or is the whole body happy if the brain's happy? I know it's important to keep the brain happy. We'll take that one. But
yeah, it's just a fascinating concept. We need to take care of the brain. If somebody gets a stroke or delirium or some sort of neural we especially an elderly patient, in the younger population, it could affect their educational capacity and function. But if you get somebody in the elderly population and they take a hit, they may not go home. They may not go back to work. They may have functional abnormalities. They're going to be put on a different, life expectancy and so forth. So we have to take care of the brain. Now, the real challenge we face is that we can't monitor these other organs very well. It'd be great that if we can know whether the perfusion to the kidney is adequate during surgery, or to the gut, or to the liver, and we could then sort of use this information to balance. Okay, the brain needs this. That's still too low for the kidney. So let's get it up a little bit higher. Wait a minute, it's a little bit too high now for the brain. And we're going to need better monitors. And whether these are monitors in the true sense of getting information on flow and oxygenation and things like that, versus even in the very near future having real-time biomarkers that we can measure in real time.
I just wanted to ask Chuck really about the response rate of the brain and how quickly we think that the brain responds to changes in blood pressure in terms of flow. Is this immediate, or have you seen delays in the techniques and experiments that you've done?
The autoregulation is really a slow process in terms it's not rapid. We look at slow waves, we call them, and they're on the order of 0.05 hertz. So it's not immediate, but it's pretty fast. It's not immediate, but it's still within minutes or last seconds to minutes. So it does adapt slowly. Our methods, we tend to look at 300-second. When we look at correlations, we look at 300-second windows, 5-minute windows, but we update it every 10 seconds. So it's a sliding window of time. So it's not instantaneous. There are ways of looking at this better. If we could look at the cross-spectral analysis of flow and pressure, such that if you know there's an input into the arterial waveform, and you can put this input in with your heart-lung machine, simply causing a little pulse, or you can put it in by a varying PEEP. Every minute raise PEEP up 5 millimeters mercury, and then you would have a change in the arterial waveform and look at the response. You could get an answer quicker. So there are better methods, and I think there's also probably this could be an area where machine learning could help, that you could take individual patients and start with one method, but gather more information as you go on this individual patients, even to get more reliability on where the right spot would be for the brain. But it'd be interesting, Dan, you have the biomarker aspect of this. I think we are a long way off, not a long way off, but it's not, I don't think, in clinical trials where we could actually look in real time at biomarker release for the kidney or for the gut.
One of the things that you mentioned that I really resonate with is that we should not necessarily rely on our population data to make presumptions about understanding the individualized patient responsiveness. Certainly that's true with respect to auto-regulatory thresholds in the brain. But I'm going to ask you to speak to how we can reconcile the data that we now have embraced with respect to population health data and defining, if you will, threshold tolerance for blood pressure, and relating the, if you will, tolerance thresholds to our understanding of predominantly myocardial and renal dysfunction outcomes that are expected to be more likely than not when we go below those sort of population data thresholds. Tether the two conversations together for us, if you will, given your now understanding of the concerns that we might want to consider when we use population data to drive individualized decision making.
Yeah, I think this is I don't want to get on a soapbox here, Sal, but I think this really speaks to the need that clinicians realize we have for defining adequate blood pressure. With the availability of electronic health records, we've now been able to sort of pick cutoffs of blood pressure, certainly in non-cardiac surgery, that are related to adverse outcomes, and thus derive maybe the blood pressure shouldn't be lower than 65 millimeters of mercury during surgery. And, this may actually indicate clinician skill or quality of intraoperative care. And I'm just going to give a little caveat. I just finished an editorial for Anesthesiology based on some new data that came from the Cleveland Clinic. But suffice to say that the data linking intraoperative blood pressure with postoperative outcomes are all epidemiology. They're retrospective data, And we now know that postoperative hypotension, blood pressure, maybe even more determinant of myocardial troponin release. So we're putting a big burden on ourselves to say that this is a metric that we should all aspire to based on retrospective data. We've been down this path before with beta blockers. Retrospective data suggested and intuitively just made perfect sense. We should beta block people. Well, wait a minute now. Let's do the proper study in the POISE 1, and we find out that, yeah, you might protect the heart, but you're going to cause more strokes and death. There's other examples where we hopped on the bandwagon of retrospective data only to have it refuted when the proper studies were done. I think of insulin, aspirin maybe. I think of estrogen replacement in elderly women. And we've been down this path before, and what is our threshold for making recommendations for quality? Is it based on retrospective, or do we need to wait for the trials? Some of these trials aren't going to be able to get done. They're going to be very difficult. So, I'm just very cautious about saying that a blood pressure of 65 should be a quality indicator because it's based on retrospective data and not on prospective data. In other words, nobody's shown that if you keep it higher than 65, and I know the IMPRESS study, but they didn't really test this hypothesis, that if you keep it greater than 65, you actually improve outcomes. And that will, of course, be the ideal data. And the other thing I really worry about is that this may be an epiphenomenon. I mean, it may be, and your own data, Sal, showing that these big excursions in blood pressure actually can predict mortality. And maybe these swings are an epiphenomenon for higher risk patients. Maybe they have diastolic dysfunction to the left ventricle. Maybe they're just sicker. And by using this as a quality metric, might we just be identifying sicker patients? And the unforeseen consequence of this is that, wait a minute, somebody's looking over my shoulder. They're saying that if I keep the blood pressure less than 65, I'm not a good anesthesiologist or anesthetist. You know what? I'm going to give this patient a miss. I'm going to not do this patient today because I don't want my externally measured quality indicators to reflect that I'm not a good anesthetist when it's actually just the patient who's sick. So I think there's a lot of implications of tagging blood pressure less than 65 millimeters of mercury for non-cardiac surgery as a quality metric. We just don't really know whether this is something that is truly modifiable. So that's my own opinion. I don't know. It may fly in the face of what other people think.
So Chuck, thank you very much indeed. You've teed this all up perfectly. The clock is against us, as often happens. So thank you for being a wonderful host, both physically and virtually. We really hope we're back with you as a physical host in the future. We look forward to closing out on this pathophysiology of autoregulation and its contributions to recovery roundtable. It looks like going to be a series of breakout meetings like this coming together as the weeks and months pass to produce a white paper. But you've teed it up absolutely perfectly for us. Sadly, we're going to let you go because we have got a limited number of chairs around Dan Martin's round table. Now, I've got a physical one here that everyone's very welcome to but not allowed to come to. He's going to take the virtual roundtable. So, Dr. Hogue, Chuck, thank you very much indeed for everything. We'll say goodbye.
Yep, thank you. Look forward to seeing you in person, Monty.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.